Hi, my name is Judy Moskowitz. I'm a professor of medical social sciences at the Northwestern University Feinberg School of Medicine in Chicago, Illinois. Today, I'm going to talk to you about our work on the role of positive emotion in the midst of stress. This work started for me 20-something years ago when I was a postdoc at the University of California, San Francisco. And I was working on a study of men caring for their partners with AIDS. This was some of the most stressful life experiences you can imagine. At the time, the treatments for HIV and AIDS were not particularly good. So AIDS was essentially a terminal illness. So we were interviewing the caregivers over the course of caregiving and through bereavement. We interviewed them every other month over the course of up to 5 years. And we were asking them about the stress of caregiving and very much taking a stress and coping lens. What's stressful? How are they feeling about it? And what are they doing to cope with it? So we were asking the participants to tell us something stressful related to caregiving or bereavement that happened in the past week. And then we would give them the ways of coping checklist. So, okay, that thing you just told us about that was stressful. Here's a list of ways people might cope with stress. What did you do? And then they filled it out. And that was the end of the interview. We'd say, thanks, we'll see you in 2 months. And shortly after the start of the study, the participants started saying that we were missing part of the story, that we weren't asking about the good things that were happening. So we started asking them to tell us about a positive event that helped them get through a day in the past week. And in almost every single interview for every participant, they could come up with at least one good thing that happened in the past week. Another finding that came out of that study was that even though the participants were highly depressed and highly distressed, as you would expect, they also had fairly high levels of positive emotion as well. So when we asked them over the past week, how often did you feel happy and relieved and satisfied and excited? They would report feeling those emotions almost as much as they were feeling the negative emotions of sadness and distress. So based on those two findings, we started thinking about what does it mean that people are able to experience the positive emotion alongside the negative, that even in the midst of some of the most stressful circumstances that humans experience, perhaps the ability to have positive emotions as well helps people cope better. There did start to accumulate in the literature. We started to accumulate some findings that showed that positive emotion was beneficial, was uniquely beneficial. And the one I always like to start with for people is that there are now a number of studies that show that people who have more positive emotion live longer. And that's independent of depression or their negative emotions or negative experiences. My favorite study to show this, and there've now been a number, but my very favorite is something called the nun study. The original purpose of the study was to look at cognitive functioning in these nuns. They had a couple convents that they were working with. So they would go in and they would assess cognitive functioning in the nuns. And then after their deaths, they would autopsy them and look for changes in the brain and try to correlate that to their cognitive functioning measures that they'd filled out previously. The researchers also had access to a whole sort of treasure trove of other types of data. One of those pieces of data was a sort of an autobiographical narrative that the nuns wrote when they came into the convent. So they were in their early 20s. They were asked just to write a page about themselves, sort of what their life had been like up to that point, what brought them to the convent to come to this life as a nun. And the researchers looked at the emotional content of the sentences that they put in their autobiography. So they looked at proportion of positive emotion sentences, also negative emotion sentences, and they looked at other things like lexical complexity, which is a proxy for IQ, which also predicts longevity. And what they found was that the nuns who had the highest proportion of positive emotion, those are these two top lines in the survival graph, were more likely to be alive out to these older ages. This is age along this axis here, so out to 90 and 95. The nuns who had the highest proportion of positive emotion sentences lived longer compared to those who had the lower proportion of positive emotion sentences. And again, this is controlling for things like negative emotion and lexical complexity. So in addition to positive emotion predicting longevity, it also predicts better health behaviors. So people with more positive emotion are more likely to have better diets, they're more likely to be physically active, and they're more likely to follow their doctor's instructions. They're more likely to adhere to their medications, for example. There was a study that came out now, what is that, about 7 years ago now, 8, that this was an observational study, so epidemiological analysis of the data, looking at positive affect, and they found that it did predict longevity or lower risk of mortality. Oops, sorry about that. When you just look at positive affect and mortality, but when you add physical activity into the model, it was a significant mediator, a significant pathway for how positive emotion or positive affect impacted longevity. So people with more positive affect were more likely to be physically active and were more likely to live longer. My colleague Adam Carrico, who's now at the University of Miami, and I published a paper showing that in a sample of people newly diagnosed with HIV, those who had more positive emotion at baseline were more likely to be engaged in care for their HIV 3 months later. So it showed this link between positive emotion and beneficial health behaviors. Another one of my favorite studies, this was done, decades ago, by Alice Eisen, who was one of the sort of first psychologists to really look at the unique correlates of positive emotion. Psychologists historically tend to look at the negative and how do we reduce the negative. And Alice Eisen was one of the first ones to say, well, there's something unique about positive emotion, and it has, and she was looking into the types of benefits that it might have. So she did a study, and this is for the physicians in the room and other healthcare workers. She brought the physicians into the lab and gave half of them a bag of candy, which is a sort of a tried and true way of increasing people's positive emotion in the moment. So she gave them candy, half of them candy, and half of them did not receive the candy. And then she gave them a case to think through and sort of talk aloud, and looked at the kinds of factors they were considering as they were coming to the diagnosis, and how long it took them, things like that. And what they found was that in the group that received the candy, they integrated information earlier. So they were able to pick out the important pieces of information in the case description and demonstrated less anchoring. So they didn't immediately go to a conclusion and stick with it. They maybe considered it, but then looked more broadly for other possibilities. They did not show evidence of premature closure or other superficial processing, and they did come to the right conclusion sooner than those who did not have positive emotion. So it was about 2007 when I was working on the caregiver study, doing some other work that we'd done in people newly diagnosed with HIV, other folks working in the field were coming to similar conclusions. And what we were finding was, first of all, positive emotion co-occurs with negative, even in the context of extreme life stress, and is responsive to the context. So what I mean by that is that what we saw in the caregivers was that although they did have elevated positive emotion relative to negative for most of the time, it was responsive to what was going on in their lives. So around the time of the death of the partner, the positive emotion went down. And then as they got farther away from that death and started to recover somewhat from the grief of that, their positive emotion went back up. So it isn't simply that there are people who are born positive and they stay positive and they live longer. There's definitely some movement around their positive emotion, which tells us that maybe you can intervene. Positive emotion has beneficial effects independent of negative emotion. And at that point, it was clear to me that someone should come up with an intervention or a way to help people have more positive emotions so that they can cope better with whatever stress they're coping with, and then maybe have improved health behaviors and maybe even longer life. The problem at that point was that I'm not really comfortable with interventions. I'm a social psychologist by training. I'm not a clinician. I mean, social psychologists have a history, like Alice Eisen did, of bringing people into the lab and doing sort of short-term mood manipulation. So you show them like puppies or kittens or babies or, happy movie clips or give them a bag of candy. Those things can give you a momentary increase in positive emotion. But I was really looking for something that could be sustainable longer term for an individual. So I went to the literature and I looked for sort of skills and behaviors and practices that had data, they were empirically based, suggesting that they increase positive affect or positive emotion. Here's the full list that we've come to choose from for interventions now. The top 8 were in the original intervention. And then since then, as we've tailored it and modified it for different samples, we've added some and taken some out. But the top 8 are really the core skills that we teach. So our lab tends to name studies using plant or flower acronyms. So I'm going to tell you about a few in just a minute, but here's a slide that depicts many of them. Iris, lilac, forest, cedars, larkspur, dahlia, orchid, marigold leaf, lavender, cypress, laurel, Artemis, and daisy are on the screen. Or Artemis is not a plant or flower, you might be saying. That's a study I'll be telling you about in a minute that Adam Carrico, who I mentioned earlier, was a mentee, and that's sort of his line of work, the Artemis work. So he gets to name his own studies. Oops. We have developed a theoretical model. This is how we think all these factors play together. So PPI is a positive psychological intervention. It's the type of interventions that we do, and I'm going to tell you a little bit about. Our most proximal outcome, our primary outcome, is always increased positive emotion. So that's our target. We teach people these skills. We want them to have increased positive emotion on a daily basis, and that ability to have more positive emotion, even if you're experiencing significant stress, has a host of sort of more downstream effects, more distal effects, like reducing your stress level, improving your preventive and other health behaviors, and ultimately improving your psychological and physical health. We've done, as I said, a number of studies. Generally, the way we approach it is we start with in any given sample, we'll do some tailoring of either the delivery mode, sometimes the language, on the examples that we use, and then we'll pilot test it. And then if we're lucky, we'll get some funding to run a randomized trial. So here's a list of some of the in-person ones we've done. We also have a number of intervention versions of the intervention that are online and self-guided. And then we've also got some that are sort of hybrid, and I'll be talking about one of those, the LEAF study, in just a minute. So let's start with that one. LEAF stands for Life Enhancing Activities for Family Caregivers, which is not my best acronym, but good enough. This was funded by the National Institute of Nursing Research, and my co-PI on it was Glenna Dowling, who's a nurse at University of California, San Francisco. So LEAF was a randomized trial to test the effect of these skills in a set of informal caregivers, a cohort, informal caregivers of all types of dementia. So it wasn't just Alzheimer's, but we also had frontotemporal lobe dementia, Lewy body disease, Parkinson's, dementia. So if you were a caregiver of someone with a dementia diagnosis, you were eligible to be in this study. The control group was daily emotion reporting that then crossed over and received the skills. And the intervention was delivered by a person, by a trained facilitator, but via the internet. When we did our pilot study, we started out by trying to have the caregivers come into the offices, and once a week for 5 weeks or 6 weeks. But you won't be surprised to hear that's hard for caregivers to leave the person they're caring for and commute in and be away for several hours to learn these skills. So we quickly pivoted to teaching them the skills live, but via, we used WebEx, but like Zoom. So just like this, they would log in at the same time, and the facilitator would go through the skill, interacting with the participant. And like I said, this was funded by the National Institute of Nursing Research. So the intervention was about an hour a week, one-on-one with the facilitator for 6 weeks. And when they enrolled in the study, we sent them these Samsung tablets just to make sure that everyone had that kind of access. And it was preloaded with WebEx and with the internet, so they could do their assessments that way too. We also sent them this really nice workbook that you see there on the right. It was, half an 8.5 by 11, whatever that is, 4 by something, and sort of wire bound like that. So with lots of extra pages for home practice, and the caregivers really loved these. So average age was about 63, 85% female, 88% white. We did have some distribution in terms of urban versus suburban versus rural. And we had really good retention in this study. The caregivers were amazing. I think, because it tends to be rare for the caregivers to have someone to ask them about themselves. They were really invested in this study, and sometimes they would call us and say, I think I'm due to have an assessment. I'd say, yeah, that's coming to you tomorrow. We'll get there. Just hang in. We appreciate your enthusiasm. Here's where the participants lived. So we did pretty well in terms of geographic distribution. This is what the design looked like. So everyone who came into the study was eligible to do a baseline assessment, and then they were randomized to either receive the skills immediately or to do daily emotion reporting. So they would get an email every day to say, what were your emotions today? And then everyone did a second assessment. And then those who'd been in the control group crossed over and learned the skills. This graph shows the effect sizes for the difference in change between intervention and control. In general, effect sizes, it's like 0.2 is considered small, 0.5 is medium, and 0.8-ish is considered large. So it just gives you a sense if you're trying to compare across different outcomes. We had thankfully, a nice effect on positive emotion. This DES positive is our positive emotion measure, such that the intervention group, their positive emotion was actually, I'll show you in a second, was maintained versus the control group. There was a dip in negative emotion, a significant drop in depression. Negative emotion was not significant. Caregiving burden decreased also in the intervention group. Wasn't significant. Perceived stress, not significant. And then we did see a significant increase in the positive aspects of caregiving, which is great because that's part of what we were teaching them, a significant effect on positive aspects of caregiving as well. When you unpack that a little bit and look at what was going on, it wasn't that the intervention group, so in green here, those who got the skills right away when they entered the study, it wasn't that they were getting this huge jump in positive emotion. It was more that they were maintaining it over time. Whereas over the course of that 6 weeks, the emotion reporting group was actually having a significant decrease in positive emotion. And then when they crossed over and received the skills, they did have then an increase, which was good to see. Oops. Sensitive mouse. So, there's a couple of things that could be going on here. One, it could be that our emotion reporting is making their positive emotion worse. That's possible. What I also think is going on is it's probably a number of things. Another thing that I think might be causing this drop in positive emotion for the reporting group is that sort of objectively, the circumstances were getting worse for everyone. So, we had the caregivers reporting to us sort of the status of their care recipient, and overall, everyone was getting worse over time, as you might expect. So it could be that the emotion reporting group, their drop in positive emotion was sort of tracking along with that, whereas the intervention group had the skills, so they were sort of maintaining their levels of positive emotion. Here's positive aspects of caregiving, sort of makes more sense here. The intervention group who get the skills first, they have this nice increase, whereas the control group really doesn't change until they receive the skills, and then they have a nice bounce up in positive aspects of caregiving as well. Depression, both groups drop somewhat on depression, which sort of argues against my my earlier point. But you see a bigger drop in the intervention group. And then when the control group receives the skills, they also show a big drop in depression. So another thing that we think might be going on here is that this emotion reporting is sort of increasing emotional awareness, and is sort of softening the ground for the skills as well. When we look at whether this the intervention sort of affects depression mediated by positive affect or positive emotion, which is part of our theoretical model, that the intervention increases positive emotion, which then helps to decrease depression, we find that that is the case in these data. We did get an effect of mediation. A couple of years ago, NPR did a study, did a story on this study, and had some really nice quotes from one of the caregivers in particular. And she said, my husband picks up on my energy, and if my energy is positive, it's easier to care for him. She's learned to focus on what is instead of what's lost. I remind myself I still have him. I can still hug him and hold him and tell him I love him, which is just such a great sort of encapsulation of the skills that we teach. So I'm going to tell you about a couple more examples of this intervention and in different samples that we've done it in. The Artemis study was done with Adam Carrico. This was funded by the National Institute of Drug Abuse. And it was a randomized trial of these same skills plus contingency management for HIV positive men who have sex with men who are using stimulants or methamphetamines. Contingency management is frequently used intervention for people using stimulants. So the way it works is you go into the site. In this case, we were working with a community-based organization in San Francisco. The participants come into the site, give a urine sample. If it shows no evidence of drug use, then they're given cash. And the longer they stay sort of clean or not showing evidence of drug use, the more they get paid. So it sort of ramps up. If they do have evidence of drug use, they're not kicked out of the study. They just go back to zero and then come in next time. And contingency management is effective, but it is really stressful. It's really hard for the individual to go through. So our hypothesis was that partnering these positive emotion skills with contingency management could help people stay in the program longer and ultimately reduce their drug use significantly. So this one was delivered face-to-face, the intent with individually, so facilitators met with the participants once a week while they were doing contingency management. So at one of their sessions, when they would come in to give their urine sample, they would also learn a skill or two. And then the attention control was like neutral writing exercises. So they saw the facilitator, they interacted with them, but they weren't learning the skills. The assessments did, the urine toxicology screening, and the questionnaires were done at baseline at 3, 6, 12, and 15 months into the study. We used these sort of original 8 types of skills, and the tailoring, some of it is sort of described there on the right. We expanded on the meditation, looking at, there's some mindfulness-based relapse prevention work that's been done, that we brought in more of that type of meditation. Here's what we found. For positive emotion, the intervention groups in green, the control groups in the orange dotted line, we found that, from screening to baseline to session 1, that the intervention group actually had quite a decrease in their positive emotion. But then as they got into the sessions and learned more of the skills and time went by, their positive emotion increased. And that was significantly different from the control condition. Oh my goodness. There we go. One of the really exciting findings from this study was we found that those participants in the intervention condition were much less likely to show evidence of HIV, so their viral load remained suppressed compared to the attention control group. So 15% of the intervention group had any evidence of HIV, so they showed some lack of suppression of their viral load over the course of the study, compared to 46% of the attention control, which is sort of a very exciting finding for us. In addition, we saw some effects on their use of stimulants, as evidenced by the toxicology screen. Right, so compared to the control condition. And I switched colors here, sorry about that. So the Artemis, or the intervention group, stayed at about showing 50% at each time point would show evidence of methamphetamine use. And the control group had more than that, and up over 60 at some points at 6 and 12 months. Okay, so I want to talk a little bit about physicians and providers, as promised. Much of this work was done by Dr. Elaine Chung, who worked with me as a postdoc and then as a assistant professor. And the work she did is based on a couple of studies. So before I left UCSF and came to Northwestern, I was working with the head of the emergency department residency program, Susan Promise. And we did a pilot where we offered the UCSF emergency medicine residents, so the first year ones, so they were interns. There were 12 of them in that class. So they were offered the intervention, they were offered the skills in an online self-guided format. So there was no facilitator in this case. They were just given access to the program that they could walk themselves through to learn the skills. Our control group, it was not randomized, but it was the emergency medicine residents at Highland Hospital across the Bay in Oakland, and there were 6 of them. So it was a very small sort of proof of concept study. And what we found when you look at burnout, or one of the aspects of burnout, which is emotional exhaustion, we found that at baseline, both the intervention group, which is in purple, and the control group in orange, they were, at about the same level of emotional exhaustion as they started their internship. Both groups increased over the first 6 weeks of their internship, which will not surprise anyone. But the intervention group increased less on this indicator of burnout over the 6 weeks, maybe because they had access to the skills. A similar pattern with perceived stress, which is a related measure. They were at about the same at baseline, and then over 6 weeks, even though both groups increased, the control group increased more in their perceptions of stress. Elaine went on to develop a program called Lavender, Leveraging Affect and Valuing Empathy for Nurturing Doctors' Emotional Resilience. This work is with Alison Ludwig at Albert Einstein College of Medicine in the Bronx. And Allison really wanted to bring this program in for all of the third-year medical students. Some of you may know the third year is when, during medical training, is when you start to see a big drop in sort of empathy among trainees. The stress is just sort of can be overwhelming. So Allison really wanted to bring these skills to the students, and it was integrated into their curriculum. So Elaine and the team went out for 4 in-person sessions over the course of their third year, the students' third year. And like I said, it was part of their mandatory wellness curriculum. And she taught them the 8 positive emotion skills. She had a website to sort of give them more of the science behind it, to give them options for ways to practice it. There were self-guided tutorials, home practice, and additional resources. And we did tailor it specifically for medical students in terms of especially in terms of the expectations for home practice. We let them know that it's important to practice these skills, but you can do it anytime, as well as the examples that we used. We made them very med student specific. The room we taught in was kind of this strange, it was a former library. So it was where the stacks used to be. So it's this long, low ceiling, narrow room that had all these tables where 10 students would sit, and they had the screens for each table. This is the students doing one of the exercises called Gratitude Pictionary, where they're drawing something that they're grateful for. So we got some positive feedback on this. The students said, I actually found myself using this a lot. I used it with my friends too. It does help and helps with coping. It's really improved my experience on a rotation I don't like. I used it to make sure little events didn't ruin the rest of my day. And my patient didn't agree with me about the importance of taking his medication. I was frustrated, but it helped me see his perspective better about his decision, even if I didn't agree with it. We also got some negative feedback. I haven't been using the skills. I'm too busy. That both of those first 2 ones have to do with it just not fitting into their lives. And the third one is actually a really important critique of the entire program, not just for med students. And the student said, while there's utility in the skills taught by the Lavender program, as a medical student, I feel it feels like a Band-Aid to have these presentations during which we are taught how to find the silver lining in bad situations instead of actually doing anything to fix the things that are causing our stress. Now, this is a really important point. There are, for medical students, for providers, for everyone in various situations, there are systemic problems. So if we just focus on medicine, the pressures of having 15-minute interactions with your patients, and the charting, the excessive charting, and the electronic health record, and all those sources of stress are not problems that an individual solution like Lavender is going to solve. What it can do, however, those problems are going to take much longer and need a different kind of attention, and they do need attention. What something like Lavender can do, though, is help the individual avoid being crushed under the weight of the stress in the meantime, right? So it's an individual sort of, I see it as like a survival skill, a set of skills to help someone survive the stress. We're not looking for them to come out the other side and just say, oh, that was fine. It's a little hard, but it's all great. That's not the point. The point is to help them cope better with the stress so that then maybe they can be part of the solution ultimately. This will all be familiar to you. At the start of the coronavirus pandemic, I was getting a lot of calls from journalists and friends, colleagues in the department, asking about applying these skills to the stress of living through a global pandemic. So our first attempt at this, we already had the version, in an online self-guided format. This was for our current study of Alzheimer's caregivers. where they're able to go in over the course of 6 weeks and do a sort of a self-guided version of learning the skills. Looks like this. So we were able to modify that and create a version for, initially it started out with people in our department. And then because I can't help myself from collecting data, we created another version that is IRB approved for anyone. So this is what the program looks like online. Each skill comes up here on the left in your daily check-in, which is emotion reporting, and the place where you can do homework or home practice. It shows you your progress through the week and your progress overall through the entire program. You can click down here and do your current skills. You can go back to previous week's skills. The home practice for each week is here. There's a discussion board where you can either, you can push your home practice responses to the discussion board for discussion, or you can go right in, you can comment on other people's. It's to try to generate some sort of social support, social cohesion as people are learning these skills. And then we also have a little bit of gamification where people get awards and badges for completing various things. And this is what the skills page looks like. You click on each one as you're going through. Each week, you have to complete the content for that week before you go to the next week. So people can't just power through all in a single day. We really want people to take a little bit of time to practice each skill before they learn the next one. So in this IRB approved version, we recruited participants from all over the US through various online sources like Research Match, through social media, through presentations like this. I will sometimes get people asking about it, and I can send you the link if you're interested in seeing more, and then through word of mouth. The data I'm presenting here were collected from May 5th, 2020 through March 2021. We are still collecting data, although as you can imagine, it's slowed down quite a bit because coronavirus is not as urgent, perhaps, or people are maybe adjusting to it. The people who enroll have access to the platform delivered over 5 weeks. They're given assessments at baseline at 8 weeks. So they get 8 weeks to work on the skills, and then we give them another assessment, and then at 12 weeks, so a month after that. And we measure depression, anxiety, social isolation, positive affect, and meaning and purpose using the PROMIS computer adaptive tests. So these assessments are really quick, and people are able to go through them in about 2.5 minutes, which is amazing. But because they're computer adaptive tests, they're very efficient and precise. So the questions I'm trying to answer here are, there's a couple. One, are depression, anxiety, and social isolation higher than general population norms, and are positive affect and meaning and purpose lower? So another one of the advantages of the PROMIS measures is that there are general population norms on them. So all those scales are normed at 50 with a standard deviation of 10. So you can compare the scores in your sample to what sort of the general population scores are normatively, right? A second question, we of course wanted to see if people who engaged in the intervention showed improved scores on these well-being outcomes. And then we were also interested in looking at whether baseline scores change over time. So were we seeing sort of adjustment to the pandemic, psychological adjustment to it over time, just looking at the baseline scores of people who came into the study. So huge caveat, there were mostly female, mostly white, mostly highly educated participants. We really didn't try to, we just sort of threw the doors open, and this is who came into the study. We didn't try to oversample. So that's a keep that in mind as we look at these results and who they might generalize to. So in terms of comparing to general population norms, we found that anxiety, depression, and social isolation were all higher than the general population norm of 50, and positive affect and meaning and purpose were lower. And that's at baseline. So as people were coming into the study. Then we also found in people who, access the intervention, so pre to post, just looking within individuals, significant drops in anxiety, depression, social isolation, significant improvements in positive affect, a tiny improvement in meaning and purpose, but it wasn't statistically significant. Okay, you might be thinking, without a control group, could these observed changes just be due to the passage of time? Is it just that people who are coming into the intervention, they would have gotten better whether they learned these skills or not? It's an excellent question, valid. One way we were able to address, so this wasn't a randomized trial, there was no control group, everybody got the intervention. But one thing we were able to do with these data was look at the scores on these measures, and this is anxiety, among people who were completing their baseline. So they hadn't accessed the skills yet. And we could compare those skills to the post assessment. So in people who'd seen the skills, did we see improvement at that same time point? So this, to some extent, can get around the cohort effect of everybody adjusting, right, over time. So if you look at people in blue who are completing the intervention for the first time, so even out here, the folks in blue, this is their baseline assessment. And then the folks in orange, this is their post assessment. If you compare those two lines, you see that the post assessment, again, this is anxiety, those folks filling out the assessment are reporting lower anxiety than those who are completing the baseline at that same time point. Similar pattern for depression. People who've had access to the skills have lower depression than those who have not yet had access to the skills. Social isolation, not quite a significant difference, but a similar pattern. Positive affect, depending on how you like to interpret your p-values, it's p.053. So almost statistically significant in terms of higher positive affect for those who've accessed the skills versus those who have not. And then meaning and purpose, we really don't see a difference. Maybe a tiny increase in meaning and purpose, but not a big one. Okay, so in terms of the questions, we did find that among people who signed up for the skills program, and we will look deeper to see if we get an effect, if there's a sort of a dose response effect. So people who do more of the intervention, do they have even more improvement? But among people who signed up for the program, though, these aspects of emotional well-being, so depression, anxiety, social isolation, positive affect, were significantly different from the general population norms. The intervention, does the intervention improve scores on these? Yes, for the most part. And do baseline scores change over time? It does not appear that they do, at least among people seeking out a program to help them cope with the stress of the pandemic. So it could very well be that maybe as a society, we're adjusting and feeling less anxious and less depressed. But among the people who maybe aren't feeling better, they're seeking out some help and like this. So that could be why we're not seeing a change in the baseline scores over time. Okay, so to look back at our entire program and the studies I've told you about today, there are some conclusions that I take away from this. These skills, this program has promise for people coping with life stress, which is everybody, no matter what type of stress it is. We have multiple feasible delivery modes, self-guided online, individual, in-person facilitated. We have tested group versions that look to be effective as well. Now our challenge is to figure out under what conditions does it work, for which people, under which types of stress. So what are the moderators of the effect of the intervention? Is there sufficient evidence that it works for some people some of the time to continue this line of inquiry? Of course. And is there sufficient evidence that it works for some people some of the time to implement it as part of standard practice? This is an area that we're starting to move into, where we're going into clinical settings and trying to implement the intervention for people who need it right there in the clinic. So we have a study right now where we're working the Ryan White the HIV clinics in Chicago and referring people with elevated depression to do the online version of the intervention. And we'll look to see if that works, but that implementation within the clinical context. This is Pollyanna. If you don't know her, she tends to look on the bright side for everything. It's important to know that this program is not about ignoring the bad things that are going on. And in fact, that's always, the first thing, or if not one of the first things that I say to journalists when I'm talking about this. I'm like, this is not about pretending things aren't awful. Things are awful. Things are bad. And feeling anxious and stressed and distressed and sad is normal and adaptive in many cases. And humans have evolved to pay attention to the things that generate negative emotions in them. Those emotions focus their attention on the things that are going wrong, that need ameliorating. So this is not about pretending like things aren't bad or pretending that things aren't stressful. It's about the ability that we have to experience positive emotion alongside the negative. And that when we can do that, we cope better with whatever it is we have to cope with. I need to thank a huge team of folks over the years. And certainly my funding has come from multiple NIH centers. And this is where you can reach me. You can find out more about our work at moskowitzlab.com. You can find me on Twitter. And if you're interested in talking about the PARC study, that's the link to it. But also I would encourage you to contact me first and I can send you some more information about it. Thank you.